Welcome everyone. Today we have the FHU IVR webinar. So I'll hand it over to our Honorable President, Professor Yoko Kato, with her opening remarks. Please.
Okay, so thanks a lot. Today we have a very honor to welcome the Professor Mohamad from USA. We're very much looking forward to his lecture, and also the Keisuke Kadooka, another speakers. Okay, so let's start.
Okay.
So maybe
we have our chairs, Professor discussions, Professor Katara Ueda. Yes, Professor Ueda, please.
Okay, so can I start?
Yes,
please.
Okay. Hello, nice to meet you. I'm Dr. Ueda from Kameda Medical Center, Japan, and it is a great honor to attend this conference, and I appreciate Professor Kato and other members of the organizing committee for inviting me to this fascinating conference. Actually, this is my 8th year as a neurosurgeon, and I've recently obtained board certification of the neurointervention field, but I still have less experience compared to the doctors who are going to give us a presentation or discussion today. So I'm truly excited to learn a lot of things from this conference. Now I would like to introduce our first speaker, Dr. Keisuke Kadooka from Kameda Medical Center, who is my supervisor. In Japan, we have long performed MMA embolization for the recurrent or re-recurrent chronic subdural hematoma patients. But as you know, in recent days, there are several RCTs that encourage us to perform MMA embolization even for primary case. And the number of procedures in our hospital has been increasing as well. Dr. Kadooka has extensive experience and deep insight into the MMA embolization, so I'm very much looking forward to his presentation. So Dr. Kadooka, please start your presentation.
Hi. Hello, Dr. Ueda, thank you for your kind introduction. I'm Dr. Kadooka from Kameda Medical Center. Let me share my presentation. Okay. Okay, let me start my presentation. Good evening, everyone. My name is Keisuke Kadooka from Kameda Medical Center. And first, I'd like to express my sincere gratitude to Professor Kato and the organizing committee for giving me this wonderful opportunity. Today, I will talk about middle meningeal artery embolization, or MMAE, for chronic subdural hematoma, including our experience with initial cases. I have no COI to declare. Let me begin with the pathophysiology of chronic subdural hematoma. As you know, the most accepted theory is the dual border cell theory. The dual border cell layer lies between the arachnoid membrane and the meningeal dura. Meningeal dura is the inner layer of dura mater. Periosteal dura is the outer membrane, and the meningeal dura is inner membrane. And Inglis, who introduced this theory, describes the layer as loosely adherent to the dura and not dense. Minor head trauma can split this layer, causing bleeding or CSF leakage. This process leads to the formation of outer and inner membranes. After that, the situation becomes more complicated. Inflammation, angiogenesis, fibrinolysis, and rebleeding. Such things occurred, which promotes hematoma enlargement. What's interesting is the difference between the outer and inner membranes. The outer membrane is highly vascularized and contributes to hematoma growth. As you see the figures on the right, you see the many arteries, vessels in the outer membrane. But in contrast, the inner membrane has few vessels As you see on the right figures, there is few arteries, vessels. And this inner membrane contributes to liquefaction of the hematoma. So the main target of MMAE is the outer membrane. Last year was a major turning point for MMAE. Multiple randomized controlled trial confirmed its effectiveness. Based on these evidences, we changed our policy before the RCTs and after the RCTs. We used to perform MMA only in recurrent cases before, but now we also perform it after Warhol surgery for initial cases. From last December, over 6 months, we performed MMA on 28 patients, 28 lesions, 22 patients. The average patient age was 81 years. It's very elderly. And we started with local anesthesia, but due to strong patient movement during the procedure, we switched to general anesthesia when possible. For early ambulation, we mostly chose transradial approach or distal transradial approach as access route. So the number of the cases of transradial or distal transradial is about double of transfemoral approaches. As for complications, 2 cases had every chance between the MMA and MMV, but they were occluded together during glue injection and didn't cause any issues. Unfortunately, we had 1 case of a symptomatic infarction. However, the symptoms improved with no modified ranking scale worsening at the outpatient clinic. And there are no symptomatic recurrence was observed during follow-up period. Today, I will introduce 2 types of MMA techniques. But first, let me explain the common procedure. For transfemoral approach, we use 4 French guiding sheaths. We usually use Fubuki dilator kit from Asahi Intech. For transradial approach or distal transradial approach, we use 6 French wrist from Medtronic. In both cases, we use a distal access catheter named Guidepost from Tokai Medical Products, and we put this Guidepost just proximal to the foramen spinosum. This position helps us switch microcatheters easily when embolizing multiple branches. We usually use the Marathon microcatheter and Chikai guide wire, and we use embolic material. Embolic material is 12.5% NBCA, very diluted one. Let's start with our conventional technique, the first technique. We advance the microcatheter as distally as possible into each targetable artery. Then we inject NBCA, and when reflux appears, we remove the catheter before it gets stuck. We repeat this for multiple branches and complete the embolization. This is a video of the conventional technique. This is an angiogram, and we navigate the microcatheter here at the distal site and injected glue. This is the tip of the microcatheter, and this contrast injection. And we started glue injection. We try to hold the position as long as possible before removing the catheter. But when we check the glue cast, the reflux is coming back here, then we removed the microcatheter. Okay. But when we checked the glue cast afterwards, we saw good filling in the main trunk, but only limited penetration into the lateral branches. The good penetration in the main trunk distally, but only limited penetration into the lateral branches. Before introducing the second technique named mid-rib pullback technique, let me show one slide. You may wonder why there is a leaf here. The central vein, please have a look on this central vein. The central vein of a leaf is called the midrib. Side veins are called lateral veins, but here we will say lateral branches to avoid confusion. This idea inspired our midrib pullback technique. We first guide the microcatheter to the distal part of the midrib, the main trunk. This is a proximal point, and we send the microcatheter like this to the distal point. And when reflux appears, we begin to slowly pull back the catheter while continuing the injection. Keep injection, but pull back little by little. At the branching point, we stop and keep injecting. It allows the glue to flow into the lateral branches. Here's a video. This is angiogram from distal access catheter, and we navigated the microcatheter to the main trunk and started glue injection. And when we checked the reflux, we started to pull back the microcatheter like this, but keeping injection. And we stopped at the branching point and kept injecting. The glue penetrates into the lateral branch and go posteriorly and downwards like this. Then we started to pull back the microcatheter again and keep injecting, and finally remove the microcatheter. And please have a look on the right figures. You can see the occluded main trunk and well-penetrated glue into the lateral branch of middle meningeal artery, and some glue going down. Okay. Here's another case. Again, you can see good penetration into the lateral branches. This is a little long movie, so okay. We started injection from the distal point of middle meningeal artery. And when we check the reflux, we pulled back the microcatheter little by little. The tip of the microcatheter is here, but we kept injecting. Injecting, and we made a small pause at the branching point, and kept injecting. The glue go laterally and downwards. And the tip of the microcatheter is here. We pulled back little by little and kept injecting. Finally, remove the microcatheter. Okay. And the glue cast, this glue cast looks like a green leaf, doesn't it? This is a midrib pullback technique. From the midrib to the lateral veins, you can see the good penetration into the lateral branches. Compared with the conventional technique, this method may allow us to embolize the lateral branches without advancing the microcatheter into each of them. So we might be able to reduce the number of microcatheters. However, by pulling back early, we may not reach the distal outer membrane completely. To compare microcatheter use, we used a metric called microcatheters per targetable artery. This number was lower in the middle pullback group. We saw no recurrence in either group, and the rate of complications was also similar. In summary, the middle pullback reduced the number of microcatheters. It also seemed to allow, at the very least, its treatment outcome is not inferior to the conventional technique. But my presentation is based on a small number of cases, so we need more and more patient accumulations. Okay, here is a conclusion. Middle pullback technique shows comparable outcome to the conventional approach, and it may reduce the number of microcatheter used per targetable artery. And it likely allows better penetration into lateral branches. And as mentioned before, this presentation is a kind of preliminary report due to small sample size. Thank you for your attention.
Thank you so much, Dr. Kadooka, for your presentation. Dr. Kadooka overviewed MMA embolizations and mentioned to some kind of technical things, and he compared the conventional therapy and mid-rib pullback technique. Is there any question or something from the discussants, doctors?
Can I?
Kimura-sensei, please.
Yes. Hello, I'm Naoto Kimura from Nansho Hospital. Thank you very much for your nice presentation. And I have one question about the indication. I think it is the embolization for the subcranial hemorrhage is very effective, but I think the cost performance is not so good because the operation fee is a little bit higher. And even if we don't do the operation, I think less than 20% is occur the recurrence. So maybe I think it's better to concentrate to the like a risky patient or the very elderly person. Do you have any comment about that?
Thank you for your question, and that is very important point, I think. And so from the last December, we kept doing MMAE for 6 months, but now we don't perform MMAE for all chronic subdural chronic subdural hematoma patients, because the reason is the same as you mentioned before. So now we select cases and we choose the patient with antithrombic agent and elderly people, and the general condition is not so good. And so now we started to select patients. Thank you for your comments.
Thank you very much. Because Japan is covered by insurance, but it's a special country, I think.
Thank you.
Okay, so Dr. Abdalkader has some questions. Please.
Yeah, thank you for this presentation and the technique. It's very interesting. The question is, do we really need to go that distal for MMA embolization? That's one question. Like the distal penetration of the embolic material, is it really necessary to prevent the recurrence? And what about, in your experience, the use of other embolic agent like coiling or even onyx embolization other than the glue? Like, do you think that there is any, obviously with coiling, you're mainly targeting the proximal branch. Do you have any preference of one agent versus the other?
Thank you for your question. In Japan, we can use NBCA historically, but we are not allowed to use onyx to occlude the MMA. So we have very limited experience, but usually, mainly we use NBCA, and sometimes we cannot send the microcatheter distally enough. Then we put some platinum coils proximal point, but we put platinum coils only for 3 or 4 patients, so we don't have enough experience to say something about proximal block and distal embolization. I'm sorry about that.
Thank you for your question. Maybe
Thank you. Yeah,
please.
I'm Masaru Abiko from Onomichi City in Hiroshima. Yeah, thank you for Professor Kadooka for your very informative presentations. And this talk is a very probably timely. And sometimes I did MMA for recurrent case, of course. Yeah. But of course, I don't have enough experience about it. So
Dr. Abiko,
yeah,
I'm sorry. The Wi-Fi is very weak now, so
really?
I couldn't hear what you said before.
Ah,
Could you repeat your
yeah.
questions?
No, sorry. Can you hear me now?
We can hear you, Prof.
Yes.
Abiko.
Yes.
Sorry. Yeah.
Could you please
Yeah.
repeat?
Yes, we can hear Abiko Sensei.
Please. Thank you for your presentation. Nice presentation. Thank you. And I of course I don't have enough experience about the MMA for chronic subdural hematoma. So in the future, do you know about the butthole surgery for chronic subdural hematoma? Or is it necessary? I think of course recurrent butthole surgery is necessary probably in the future, of course. But how about it? For example, only MMA is good for chronic subdural hematoma, or not necessary irrigation surgery. But I don't think so. But how do you think about it?
Thank you for your question. I agree with you, and I think the butthole surgery is necessary in the future because the patient will come to the hospital with some symptoms. So such severely symptomatic patient needs irrigation, but the patient with recurrence or very slight symptoms can be treated by embolization only in the future, I think. Yeah. So the patient needs irrigation, but in the future, we may treat the slight symptom patients or no symptoms, but the patient has some recurrence. We can treat by embolization. Thank you.
Mr. Rajat?
Yeah, thank you, Kadooka Sensei, for this wonderful lecture. Two points I would like to make about this. The Society of Vascular and Intervention Neurology. The SWIN guidelines came up last month. I think Dr. Mohamad Abdalkader was one of the author in that. He can expand a little further on the indications. And one another study that really caught my eye was from Iwate, Japan, which came last month, just last month, between middle meningeal embo plus chronic subdural with middle Gorisan or chronic subdural with Gorisan alone. It was from Iwate, Japan, and they found no added advantage of adding MMA to the traditional Japanese Kempo medicine. So I was surprised by this. What have you to say, Professor Koduka?
Thank you for the question. And I'm sorry, I have never read the article yet, but we usually use Gorey-san for the patient of chronic subdural hematoma, and we feel it is very effective. So we will keep administrating Gorey-san for the patient of chronic subdural hematoma, but I believe I believe the middle meningeal artery embolization will also effective for the patient. And I think that if we can achieve the embolization of outer membranes from the distal part of middle meningeal artery, it is very effective, I think. But in some cases, we finish with only putting platinum coils in the proximal part of the middle meningeal artery. In such patients, the effectiveness is will be limited. So we should check the type of the operation and the patient characteristics and everything to say something about the efficacy of embolization and Gorey-san and something. Could I answer your question?
Thank you so much.
Thank you.
You can go ahead, Dr. Gueda.
Okay, so thank you for the discussion. And now we want to move to our second speaker. Our second speaker is Professor Mohamad Abdalkader, a board-certified diagnostic and interventional neuroradiologist at Boston University, USA. I've heard that he has an impressive number of publications and extensive experience in the field of neuro and vascular surgery. Today, he'll give us a presentation on pulsatile tinnitus and its endovascular management. I'm really looking forward to hearing his talk. So, Dr. Abdalkader, please start your presentation.
Good morning. Good evening, actually, for you. Do you see my screen?
Yes.
Yes, we can see.
Great. Well, thank you for having me. It's a great pleasure to be among you today, and thank you for the great presentation about MMA embolization. We're going to switch gears a little bit and talk about, unfortunately, less common, or actually more common, but less underserved the symptom, which is pulsatile tinnitus. It's underdiagnosed, undertreated. So we're going to go to overview about the endovascular treatment. And one disclaimer that I'm going to be focusing just on venous causes of pulsatile tinnitus, like arterial causes are very rare, arteriovenous are even rare, but they're only fistula. So I think we're going to be focusing mainly on the venous causes, which is the in our experience is the most common cause of pulsatile tinnitus. So I have no relevant disclosures. And so venous pulsatile tinnitus is the most common cause of PT, and it's usually due to either structural or flow abnormalities in the venous system next to the ear. And as you can see with this nice imaging here, that the ear, especially the inner ear with the cochlea and the vestibule, are very closely related to the venous structures of the posterior fossa, from the transverse sinus to the sigmoid sinus, superior petrosal vein, jugular bulb, and the interjugular vein. So those are usually under-recognized and under-reported by the radiologist. And to complicate things a little bit more, they are Most of them may be incidental and can be seen in patients without pulsatile tinnitus. So I do prefer to classify or to categorize those venous causes into three main categories. One, the category is related to the lateral sinuses, which is the transverse and the sigmoid sinus. Pathology is related to the emissary veins. Pathology is related to the jugular veins and the jugular bulb and the internal jugular vein. So for the lateral sinus, we can divide them between the transverse sinus pathologies and sigmoid sinus wall anomalies. Transverse sinus, which is mainly transverse sinus stenosis, it can be due to either intrinsic or extrinsic. And we're going to go to the transverse sinus first. Transverse sinus stenosis, as I said, we can divide the stenosis of any venous system into intrinsic or extrinsic. The intrinsic, if there is something sitting within the vascular wall; extrinsic, if there is something compressing from outside of the boundaries of the vessel wall. If we're going to focus on the intrinsic one can be due to multiple etiologies. It could be due most commonly to arachnoid granulation, which is some CSF of lymphatic protrusion of the CSF spaces into the jugular, the transverse sinus, or can be due to meningocele. Meningocele is something also an outpouching or of the CSF spaces within the transverse or the sigmoid sinus. It also could be inside this meningocele. There could be a brain herniation, or what we call a focal encephalocele. Sometimes also a thrombus within the vascular wall can cause intrinsic stenosis and very unlikely tumor. So those different causes of venous stenosis, they are usually typically causing intrinsic stenosis, and they can cause pulsatile tinnitus. So how pulsatile tinnitus will manifest in those patients, we're going to see in the next slide. So for example, this is a CAT scan of a patient presenting with right-sided pulsatile tinnitus, and this is non-contrast CAT scan. You can see the filling defect, and on the CAT scan, you can see them as CSF density, like they are dark on the non-contrast imaging. And on the MRI, they have very typical appearance. If you can see here, they are also T2 hyperintense, and they have lobulated borders with some septations in the middle. So this is very typical for intrinsic stenosis due to arachnoid granulation. On the MRI post-contrast, you can see that this is the transverse sinus. They are obviously non-enhancing, except of the septation within them, they may be a little bit enhancing. This is on the axial, and this is on the sagittal. You can see the polylobulated appearance and the septation within. So the theory or the mechanism of how an arachnoid granulation will cause pulsatile tinnitus is what we call the eddy currents. If there is a rock in the flow of the river, this is going to create turbulence of the flow in the vicinity of this obstruction. And this is very nicely illustrated here. This is computational fluid dynamics, where there is arachnoid granulation. This is the simulation from a real MRI. Or real imaging of this patient, where you can see the stenosis. Fortunately, you cannot hear the sound here, but they were able to simulate the sound created by the disturbance of the. So this is a case of a 40-year-old woman who presented with left-sided pulsatile tinnitus. As you can see here, this is the MRI showing a round filling defect in the left transverse sinus. It's T2 hyperintense. When you can look, this is the venogram showing the obstruction or the stenosis of the transverse sinus by this filling defect, and this patient was treated by stenting, as you can see here, with significant improvement of the flow and resolution of the pulsatile tinnitus. This is just another lady who presented with headache and right-sided pulsatile tinnitus. This is an MRV of the head, and that was interpreted as a venous thrombosis. You can see the transverse sinus here, the sigmoid sinus, and you can see the filling defect. So that was interpreted as venous thrombosis. However, if we look closer and we look at the T2 high resolution images, you can see what was interpreted as a filling defect is actually due to a part of the cerebellum. Right, so you can see this is the cerebellar foliae going through this filling defect and causing the stenosis. So this is technically a cerebellar encephalocele and not like a thrombus. And this is another example. Those encephalocele can usually be either from the cerebellum or sometimes from the temporal lobe. This is sagittal MRI showing the inferior temporal gyrus here protruding into the transverse sinus. So this could be also could result in seizure or headache on those patients. So this is just another example where you can see on the axial T1 post contrast imaging, you can see the filling defect into the right transverse sinus. On the T2 high resolution images, you can see the CSF component of it and maybe some brain starting to protrude into the sinus. So those are usually on the venogram, they are from the inferior aspect of the transverse sinus, as you can see here, and they respond very well to stenting. As you can see here, this small filling defect has been pushed inferiorly by the stent. So this is before and after stenting. So it's very important to know that not all arachnoid granulations are symptomatic. Most of those arachnoid granulations are normal structures. They only can be symptomatic or cause symptoms if there is turbulence of the flow. So for example, this is patient presenting with pulsatile tinnitus. You can see this filling defect here on the imaging, on the CAT scan, on the angiogram and 3D venogram. In that, just because the symptoms were not very typical for venous pulsatile tinnitus, we did a balloon test occlusion, and the patient symptoms did not change with the occlusion of the balloon. So it's very important to know not every arachnoid granulations are symptomatic or pathological. And obviously, in case of doubt, balloon test occlusion in a awake patient may be helpful. So the second category of venous stenosis can be due to extrinsic stenosis, and those are very typical in patients with intracranial hypertension when there is increased intracranial pressure and displacement of the temporal lobe into the sinus, causing a wide-based stenosis of the sinus. As you can see here on the sagittal MRI, you can see how, because of the intracranial hypertension, part of the brain is herniating. And the way we differentiate them between intrinsic and extrinsic is like how big is the base of this protrusion. And as you can see on the on the venogram here, like you can see the wide extrinsic tapered appearance of the sinus. So the extrinsic venous stenosis, or usually a long segment venous stenosis, is considered the most sensitive sign imaging finding in IIA. So it's very important to, if you see on imaging this wide base or long segment of stenosis, to work up those patients for intracranial hypertension. Those are usually middle-aged women, and this has been present to be seen in 94% of those cases. So this is a patient with intracranial hypertension. You can see this is a lateral view of a carotid angiogram on the delayed phase. You can see this superior sagittal sinus here, the transverse sinus. You can see the tapered appearance of the transverse sinus and the concavity. And this is usually, as we said, it's from the temporal lobe pressing on the sinus from above, and this is after stenting. So stenting, we usually, for those patients, we use longer stent. This is, for example, here a 6 centimeter stent and usually 8 millimeter diameter. This is just another example showing on the sagittal MRI. This is the temporal lobe here. This is how the brain is protruding, and this is how there is stenting will push back the brain to restore the blood flow in this region. So that was about the transverse sinus stenosis. As we said, we divided them between intrinsic and extrinsic, or we can also divide them between intracranial hypertension or without intracranial hypertension. Now we're going to move to the next category, which is sigmoid sinus wall anomalies. For the sigmoid sinus wall anomalies, we can divide them into either sigmoid sinus diverticulum or sigmoid plate dehiscence. A diverticulum is usually outpouching or aneurysm formation at the junction of the transverse and the sigmoid sinus. This diverticulum usually protrude into the sigmoid bone or the mastoid bone into the inner ear structure or toward the inner ear structure. There are a lot of outstanding questions about their etiopathogenesis, classification, and management. So regarding the etiopathogenesis of these lesions, there are some theory, I would say, saying that those are secondary to remnant from the embryonal fetal life and due to remnant of the petrosquamous sinus. And this may be true, right? Like this is an example here. You can see the catheter into the transverse sinus. You can see the stenosis and you can see the diverticulum here. For in this patient, you can clearly, this is my microcatheter going inside this diverticulum, and you can see the connection with the petrosquamous sinus, right? So this is the petrosquamous sinus. It's present here. So this could be a remnant, embryological remnant. But in our experience, we do believe more that those are secondary lesion to poststenotic turbulence due to high velocity or shear wall stress on the sigmoid plate. This is a computational flow dynamic imaging showing that in patients with stenosis, there will be a lot of shear wall stress, increased velocity, hitting on the sigmoid plate and causing this progressive erosion of the sigmoid plate and leading to the diverticulum. All those parameters have improved significantly after stenting. And this is clear evidence that a primary stenosis can lead to a sigmoid sinus wall anomalies. This is in also our series. We treated 20 plus venous diverticulum, and in every single case of diverticulum, they were associated with venous stenosis. As you can see, in each single one of those diverticulum, there was adjacent stenosis, either intrinsic, extrinsic, or mixed stenosis. This is different patients on the lateral view. You can see the stenosis and the diverticulum in each of those cases. So we do think that it's an acquired lesion, and this is a nice case from our center. So this patient happened to have, or actually presented in 2020 with a right-sided diverticulum. As you can see, this outpouching into the sigmoid plate going toward the ear. This patient happened to have in our center another CAT scan 13 years before. So 13 years before, she presented for another reason, for trauma or something, and happened to have a CT scan and you can clearly see that this sigmoid plate was present back in 2007. So that's what we believe, that those the venous diverticulum are secondary lesions and not a primary lesion, especially in patients with symptoms. This patient happened to have intracranial hypertension, progressive gain weight that probably lead to venous stenosis. We're going to show her case in a later slide, and cause secondary erosion of the sigmoid plate and venous diverticulum. So how do we manage those patients? As we said, that this is the same patient that I was just showing her CAT scan. So this is the patient that we ended up treating her. So initially I treated just the diverticulum. You can see this is the 3D venogram. This is the venogram, 2D venogram here showing the stenosis and the diverticulum. So initially I decided just to treat the diverticulum, right? Like you can see here, this is coiling, simple coiling of the diverticulum with relatively good occlusion and stopping of the flow inside this diverticulum. However, unfortunately, this patient did not fully improve. She reported some improvement, but her symptoms were back, and she ended up needing another procedure. So this is a second procedure that was performed later on her. You can see here better evaluation of the stenosis, and I ended up doing stenting of the stenosis. So the message from this, and this is just the stenting, and this is the treatment before or after coiling and stenting. You can see the difference between the baseline and with restoration of the flow and treatment of the diverticulum. So I do think this example is very important, because I strongly believe that with every patient with diverticulum, we have to look for associated stenosis. Usually it's upstream to the diverticulum, and I strongly believe that this stenosis is not only the cause of the formation of the diverticulum, it's the cause of the ringing or the whooshing sound or the pulsatility on those patients. So now we primarily treat the stenosis, not the diverticulum. This is just another example. You can see here, this is the stenosis here, this is the diverticulum here. I treated this patient just with stenting. So, and as you can see here, even though I was able to get into the diverticulum, so I did not end up treating it. And this is, for my surprise, the patient, you can see the diverticulum and the dehiscence here. The patient grew the bone back. Like you can see here, the CT scan before and after, you can see a new bone formation in the diverticulum. When you stop the turbulence of the flow here, the bone will regrow back. So this is really very interesting. And this is another argument that those diverticulum or dehiscence are secondary lesion, and if we treat the primary lesion, which is the stenosis, those don't necessitate treatment and may grow back. So this is just, you see the bone growth after 3 months from stenting. This is just another example from our center. You can see here the dehiscence, the diverticulum here. Patient ended up stenting for adjacent stenosis that you don't see here. You can see clearly the bone growth on the follow-up imaging. So the question is, do we really need to treat those sigmoid sinus dehiscence or diverticulum in patients with transverse sinus stenosis? So we looked into that, and we showed clearly that there is really no need for treatment of the dehiscence or the diverticulum in those patients. So we looked at all patients who presented to our center with pulsatile tinnitus and found to have transverse sinus stenosis and sigmoid sinus wall anomalies, and we found no difference in outcome of those patients who underwent just stenting and those who underwent coiling and stent-assisted coiling. So we concluded that stenting alone is enough to resolve PT in patients with transverse sinus stenosis and sigmoid sinus wall anomalies. And this is just another example from our series showing the growth of the bone just next to the stenting. You can see before and after. So the sigmoid plate dehiscence, I do think it's just a spectrum of the disease. So dehiscence or diverticulum, they are just a spectrum of the same disease. By definition, dehiscence is the thinning or missing sigmoid plate. It can be seen incidentally, but in patients with pulsatile tinnitus, we have to always look for associated transverse sinus stenosis and intracranial hypertension. And again, the same mechanism is just like if you hitting with high shear wall stress, high velocity of the blood on this bone, you will end up with erosion. This is a picture from Vancouver, Canada, showing that how in Iraq, with continuous drip of the water over 15 years, 25 years, and 50 years, how the erosion. I do believe that those lesions are secondary to the same mechanism. This is a patient who ended, he had stenosis here with left-sided pulsatile tinnitus, so had stenosis and diverticulum, and only treated with stenting, as we were just discussing. I left the diverticulum alone. But 6 months later, the patient came back with a PT. So obviously, this patient, you can see not only the diverticulum, there's also clear dehiscence of the bone. So this is very clear example of sigmoid sinus dehiscence. You can see the window here where there is missing sigmoid plate and exposure of the flow directly to the ear. So this patient obviously now she's coming with recurrent of the symptoms. So I initially decided to place coiling in this region. However, as you can see here, it was very wide neck diverticulum and the coiling were going all over the place. So I decided to place, as you can see here on the reconstruction. So this is the stent going through the stent with a microcatheter, and this is the window. This is the bone dehiscence that we see. So what I decided here to place, we decided to place web device. So now web device, we use it commonly in the United States for treatment of brain aneurysms, but I believe that for this case, it was a good indication. So I decided to place this web device in across the window or across the dehiscence. So as you can see here, this is the microcatheter. That was a via microcatheter, and you can see deployed coming from the other side because of the orientation or the projection of the lesion, and deployed the web device. As you can see here, this is the 2D images. This is the catheter from the other side, the contralateral side. This is the microcatheter through the stent, and this is the web device deployed in this focal dehiscence. This is the CAT scan before and after. As you can see here, the web sitting exactly where the dehiscence is. And the patient's symptoms completely disappeared after the procedure. I still don't have a long-term follow-up, but immediately after the procedure, the symptoms were completely resolved. So we're just gonna move quickly to the next few slides about the emissary veins. And emissary veins, we can divide them into mastoid emissary veins, condylar emissary veins, or the petrosquamous vein. So those are normal structures. They only can cause symptoms if they are enlarged or very close to the ear. This is a lady when in her 60s who presented with 3 years history of right-sided pulsatile tinnitus. On the imaging, you can see that there's a large right-sided mastoid emissary vein and the small side left-sided emissary vein. So just as we said, it could be seen in normal patients or could be a normal structure. So I decided to do an ultrasound. This is very accessible, just over the mastoid prominence here. Just put the ultrasound probe. So this is the dilated vein before, and on the Doppler, you can see clearly the blood flow. This is the mastoid bone, and this is the mastoid emissary vein. So under angiogram, and I put the ultrasound over and I compressed over this bone, you can see that the vein, the emissary vein from the sigmoid sinus, has disappeared after the compression with the ultrasound probe. And that was done under awake sedation, and the patient's symptoms completely disappeared. So that's why how we confirmed that this enlarged emissary vein is the cause of the pulsatile tinnitus. So we then decided to treat it, and this is the sigmoid sinus, this is the emissary vein, and you can see the treatment before and after coiling, just simple coiling of this emissary vein, and the symptoms completely disappeared after the procedure. It's very important to be careful that not all emissary veins are treatable or should be treated, because some of the enlarged emissary vein can be due to jugular stenosis. This is really very important to keep in mind, that if a patient with jugular stenosis, then those emissary veins are just the collateral flow and we should not take them down. So this patient who presented with enlarged emissary vein, you can see the mastoid emissary vein, the condylar emissary veins, but you can see clearly that there is significant stenosis of the jugular vein and significant gradient across the stenosis of approximately 9 or 10 millimeter mercury. So not every emissary vein should be treated. Careful attention should be made on the jugular vein to rule out jugular stenosis. The last category is the jugular vein anomalies, and we can divide them into high-riding jugular bulb, jugular bulb dehiscence, or jugular bulb diverticulum, that they are all seen in this panels here. So this is the jugular bulb, high-riding jugular bulb at the level of the basal turn of the cochlea, jugular bulb dehiscence with missing bone with the middle ear, and the jugular bulb diverticulum and the clear outpouching of the jugular system. Those are usually also not easy to diagnose and not easy to treat. As you can see, this patient presented with left-sided pulsatile tinnitus for 43-year-old, like long-standing pulsatile tinnitus. You can see the CAT scan here, like higher cut at the level of the temporal fossa, and this is the posterior fossa here. You can see that there is not only you can see the high-riding jugular bulb on the left side and jugular bulb diverticulum, but interestingly, this patient did not have transverse sinus at all. So there is really agenesis or this lack of the transverse sinus on both sides. So how this patient is draining the blood, she's draining the blood through an occipital or occipitomarginal vein or sinus, as you can see here on the sagittal view, on the axial view at the low. So this patient was diagnosed with agenesis of the transverse sinus and persistent occipital sinus and jugular bulb diverticulum. So this is just the angiogram or the venogram showing the lack of the transverse sinus and the lateral sinuses, the occipital sinus, and the jugular bulb diverticulum. And this patient also has a stenosis of this occipital sinus, as you can see here. You can see clearly that this is the occipital sinus and there's severe stenosis here. So how we're going to treat this patient who also presented with signs of intracranial hypertension because of the venous outflow stenosis here. So I initially decided to do a balloon angioplasty. As you can see here, we improved now the flow, and then I ended up putting stent just because the stenosis there is extrinsic stenosis. So put it in stent, and after we placed the stent, you can see the stent here. I also ended up putting a web device into the jugular diverticulum. You remember, you don't see it very well here, but this jugular diverticulum was dehiscent also at the level of the middle ear. So basically, this patient ended up having balloon angioplasty, stenting, and web of the jugular diverticulum. So this is the images before, and this is the images after, and you can see the improvement of the blood flow and the web device in the ear. So this is the follow-up CT scan on this patient. You can see there is no more flow. The web device sitting very well on top of the stand, and there is no more flow in the ear here. The patient's symptoms completely disappeared after 43 years. I think still have just one time for one more case. So this is patient with 5 years history of pulsatile tinnitus. You can see here she has transverse sinus stenosis. It's intrinsic stenosis through arachnoid granulation. There's obviously gradient of pressure of 49 and 29, approximately 20 points of gradient. She also has sigmoid sinus stenosis, also due to intrinsic stenosis, as you can see here. So this patient ended up initially getting a transverse sinus stenosis, stenting, as you can see here, with significant improvement of the gradient, but there was still some gradient. And then the patient came back with residual tinnitus. So she ended up having coiling of this large emissary vein. And then she came after a few months with the new symptoms, which is juxtastented stenosis. So you can see here, this is before, this is a new stenosis next to the stent. So this patient really have refractory intracranial hypertension. And as you can see here, now that's why I told you we use longer stent now to avoid the juxtastent stenosis. So this patient ended up having another stent, but a few months later, she came back with residual headache and pulsatile tinnitus. So I ended up treating her distal stenosis of the occipital sinus. So finally, she ended up having stenting of the transverse sinus, the lateral sinus, juxtastent stenting, emissary vein coiling, and occipital sinus stenosis. So the message of this case that those are not easy cases, and some of them will necessitate multiple treatments. So it's very important to diagnose them well, especially for those young patients who may have underlying intracranial hypertension, which causing multifocal disease like multifocal stenosis, like emissary vein, and different stenosis of the different system. So it's very important to keep that in mind, that those patients may necessitate multiple treatment. And I think this is my last slide. So this is just a summary of all the pathologies that we reviewed, and I'm happy to take any questions.
Hey, thank you so much for the wonderful lecture, Dr. Abdalkader. He overviewed the venous causes of pulsatile tinnitus and mentioned to the treatment and vascular management. And some of the reason was very new to me, and I was very impressed. Is there any question from the audience?
Commentator? Yes, please.
Yep. Thank you, Professor, very much. Thank you very much. Very impressive, and it was very interesting for me. In your experience, what is the key point for selecting patients for venous sinus stenting? Professor, please. What is the key point? I have no experience.
Yeah.
Yeah.
So we are very selective. We obviously don't treat everyone. So I can divide the indications into two major indications. One is patient with intracranial hypertension, and for those patients, they have to fail medical treatment to be considered for stenting. One, and they have to have severe symptoms that necessitate invasive procedure like venous stenting. They have to have, most of those patients, they have to have either papilledema, like visual symptoms. We don't just put a stent just because of headache. They have to have papilledema on the exam or visual disturbances. They have to have usually a high opening pressure or a gradient of pressure on the venous manometry. So very, very rarely I treat patients with not with no evidence of a gradient, or very rarely I treat just patients. So again, they have to have severe symptoms, they have to fail optimized medical treatment, right? And they have to have a gradient across the stenosis. So those are the three main criteria for the now I also treat a patient with stenting if they have disabling pulsatile tinnitus. Right, if the pulsatile tinnitus is significantly affecting their quality of life, if they cannot sleep because of the pulsatile tinnitus, if they cannot really function or concentrate, and they fail. And for those patients, I also are very, very strict about ruling out intracranial hypertension, because if they have intracranial hypertension, then medical treatment. So, and then for all those patients, I do it's not balloon test occlusion, but I do the jugular compression on the jugular vein. I just see if their symptoms will improve or not. I found this very reliable to tell me if those patients will potentially benefit of stenting or not. But those patients, they don't necessarily have a gradient, right? Like, and they don't have, I do think they are the lower spectrum of IIH, but they don't have the full spectrum of IIH, like visual problem or high opening pressure. So for those patients, I discussed with them very clearly that, stenting may help, but it's still like they will need dual antiplatelets. It's an invasive procedure, and I only treat them if they are very, very affected by the pulsatile tinnitus. So that's how I choose my patients for stenting.
Thank you. Thank you for, for your information. Thank you.
Dr. Kimura, do you have any opinion or question?
Actually, I wanted to ask about the antiplatelet therapy, but the professor already solved the problem. So thank you very much for your presentation. I think it's the very big point is how to recruit the patient, I think, because the home doctor have to diagnose first. And after that, it's very difficult to make a good quality image to make a diagnosis. How do you make a connection to the home doctors or the primary
Yeah.
doctor?
Yeah, it's a big problem. Unfortunately, a lot of those patients suffer and struggle, and they are like, doctor shopping from, neurologist to, you really have to partner with your ENT colleague, with the ear, nose, and throat doctors. I think in our institution, and your obviously ophthalmology, right? Yeah, unfortunately, a lot of those patients, they're not coming from primary care, right? Like if they go to the primary care, they send them first to neurologists, and unfortunately, some of them they send them to psychiatric. Oh, you don't have anything. I really have to point out here that most of those conditions that I showed, they're also missed by radiologists. Radiologists think that, well, those are normal variant, right? Like, but in patient with symptoms and ipsilateral finding, I think those should not be, dismissed and should be acknowledged. So the primary care, they send them to imaging, and the imaging came back negative, right? Like normal. Right, and then those patients will be lost. But I think the two in my practice, ENT and ophthalmology are the main referral, right? When your ENT colleague know that this is vascular problem causing the ear problem, then they will, send you those patients. So my main source of referral is the ENT and the eye doctor, not the primary care. I agree with you.
Thank you very much.
Is there any question? Can I ask you one question?
Yes, please.
Thank you for your lecture. And what kind of medical management do you do after the stenting? Do you use like antiplatelet therapy or something, or just no medicine?
No, I think we are probably borrowing all our antiplatelet regimen from the arterial side, from carotid stenting or intracranial stenting. So I do basically the same. I start all those patients for potential stenting for 7 to 10 days of blood thinners, usually aspirin and Plavix. And I do test them for resistance. I think this is really very important, right? You don't want like this young patient to end up with thrombosis of the vein of Labbé or so very, very important to test for resistance. 25% they may have resistance to Plavix, and I've seen thrombosis on those patients. So I am very strict with the dual antiplatelets before and obviously after. And after, it's just we don't know like for how long we have to keep those patients on blood thinners. I personally keep them for at least 3 months of dual antiplatelets. So similar to, carotid stenting. And I see them in clinic usually at 3 months with imaging just to make sure that everything is okay. If everything is okay at 3 months visit, I stop the one blood thinner, which is usually the Plavix, and I keep them on aspirin for 1 or 2 years, right? So nobody knows what's the optimum protocol or regimen for medication, but I think it's better to be on the safe side for those patients. So I think it's better. But I think hopefully the stenting is relatively new thing in our endovascular, and I hope within the next few years we'll have better antiplatelet regimen for those patients. I don't believe that we should treat it as the arterial side. The endothelium and everything is different, so they may not have the same risk of thrombosis as the arterial side, and therefore I think better antiplatelet regimen is needed.
Thank you so much. Dr. Kadooka, do you have any question or
Yes.
opinion?
Yes. Thank you for your excellent lecture. And I have one question. And as for the sinus stenosis, do you prefer PTA first or primary stenting?
Very good question. As we said that in those patients with intracranial hypertension, I do believe that the primary cause of the stenosis is the extrinsic compression, right? So even if you do angioplasty, if you are not treating the primary cause with the pressure from outside, those will rebound and bounce back and shut down. So I don't believe in just angioplasty as a primary solution for those patients because the brain will come back, right? Now, some patient the stenosis is very severe. I do in 20-25% of the cases, I do angioplasty just to open the space to place the stent. So just, kind of for catheterization. But I don't think that it should be used as just the primary or the sole treatment for those patients because the symptoms will come back. But sometimes it's needed just for pre-stenting, just to create a channel or to those stenting, they are stiff system. And by the way, all the stenting I'm using, they are borrowed from the body, right? From either the common femoral stent, like Zilver stent, or from the biliary stent. We don't have dedicated intracranial stent for the venous system.
Thank you very much.
Okay.
Roger? So Mohammed, thank you very much for a great talk. So just the algorithm of the examination for the patient who has Pulsatile, the very severe the tinnitus. So the firstly maybe the MRI, then a CTA, and finally the angio. What is your opinion?
Yeah, it depends. I don't think both CT and MRI are needed. I think it all also go back to the clinical presentation. If they are presenting to me with mainly intracranial hypertension, like they are obese, middle-aged, women at childbearing age, I do MRI because I don't want I know that I have to see the eyes, the optic nerve, the empty sala turcica. So if they are more IIH, I do MRI as the baseline imaging, and MRI obviously with contrast, right? I want to see the veins, and if they are more like not obese, if they are more kind of pulsatile tinnitus picture. So I think the main thing here is just to try to categorize your patient between IIH or PT without IIH. If they are pulsatile tinnitus without IIH or without the rest of the spectrum of IIH, I do CT scan because I want to see more the sigmoid sinus wall anomalies. So sigmoid sinus wall anomalies is very common, and you won't be able to see the sigmoid sinus wall anomalies on the MRI, right, because of the bone susceptibility artifact. So I think this is grossly the algorithm. If patient presenting with more IIH pattern, I do MRI. If they are presenting with more PT, I do a CAT scan to look for the bone structures as well. Now, I don't do or jump directly to angiogram or venogram, right? If they are IIH and not diagnosed with clinical IIH, I send them back to the neurologist to evaluate them with spinal tap, with, start them on Diamox or Topamax, just for optimal before I consider them, because what's the point of doing angiogram, venogram if I'm not going to do stenting, right? If they respond to medical treatment. So if they are IIH picture, I send them back to the neurologist for formal evaluation for intracranial hypertension with spinal tap. And if they are PTE, and now I do CT scan, if I see structural cause of their PTE and they are severely disabled by their symptoms, there are different scores to use. And then I take them to the angiogram, venogram for evaluation, potential balloon test occlusion. And that's grossly the protocol that I follow.
Thanks. Thank you very much for congratulations, you talk. So back to Dr. Kotaro Sensei, please.
Yes. Yeah.
You can wind up the session, Prof.
Yeah. Maybe. Does anybody has any more question or some comments? Oh, okay. So today we had two speakers, Dr. Keisuke Kadooka and Dr. Mohamad Abdalkader. And Dr. Keisuke taught us about MMA embolization, and Dr. Abdalkader taught us very comprehensive course of pulsatile tinnitus and management. So it was very a wonderful lecture, and it was very teachful to me too, and to everyone who is attending in this conference. Thank you so much for inviting me, and I'll give this back to Dr. Kato, Professor Kato. Thank you.
So thank you very much. I think the two talks is very, very important. But we need to open the eye because most of the neurosurgeons just make a one bar hold and the irrigation is very fast. But I think a chronic subdural hematoma, the disease itself is a whole membranes disease, not only the one bar hole surgery. So I think we must tell many of the neurosurgeons necessity of the embolization of the SCA and also the Mohamad. Maybe I think most of the cases went to the ENT, of course. Maybe we can have more collaboration with the ENT and clinic doctors. I think it's really impressive, of course, and very, very important talk. Thank you very much for that, both of you. Thank you very much.
Thank you very much. With that, we come to the end of this webinar. I hope everyone was it was very informative to everyone, and this will be archived on our YouTube channel. You are welcome to watch at any time. Thank you very much for joining. Bye-bye.
Thank you so much. Okay.